Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. So today I kind of wanted to just bring something to your attention that I'm seeing more and more of. And it's actually pretty disheartening to me because my job is to not just give you information that's accurate, but also to make sure that, you're not falling for some of the bad actors, if you will, that, are in medical billing, unfortunately, in this space, because it could have serious consequences for both healthcare providers, for you, and for your patients. For example, for your patients could be charged for services they didn't actually receive, and, that could lead to unexpected and possibly unmanageable bills. I keep thinking of the issue that I mentioned a couple weeks ago on the podcast about providers that are changing from chronic care management services, which are time-based services, to now advanced primary care management services, which do not give you the burden of having to prove time, but you still have to prove that you did the service. But I'm seeing more and more health systems say, no, we just have to offer it. But if the patient doesn't use it, we're going to still charge it. And I'm like, are you insane? Who told you to do that? I don't read anywhere where it says you don't have to still do the service. You have to have that comprehensive care plan. You have to reflect that you are checking in on the patient. The whole point of care management services is to make sure that the patient isn't going to be readmitted into the hospital, that you are monitoring them for anything that's going on. And if you're not seeing them, how do you prove that you're monitoring them? And so that was one thing. And again, I always use the reference, it's not a gym membership. How many of us have gotten a gym membership but never go and they still charge us? That's not what this is. That's why, we can't have nice things, because I'm seeing this all the time. Also, it can lead to, for patients, it can be substandard care if you're listening to bad actors in this space and divert resources from patient care that they actually need. And so it also can be a loss of trust in your provider. For healthcare providers, you could have legal repercussions, face heavy fines, civil or criminal charges. You could, put your medical license in jeopardy. Financial impact, audits, penalties, required repayments, and takebacks. Not to mention your reputation. You could be also excluded from federal programs. So you need to be vigilant in identifying and reporting potential Medicare fraud possibilities and protect yourself from this. And also do the sniff test. If it doesn't smell right, don't do it. If it's something that is questionable, hopefully you remember and run it by me first. I had a couple of things today, and I mentioned the ACPM. Look at this other one that I had recently, and I want to thank one of my members for sending this over to me because I thought this was interesting. She said she was in a course recently where one of their surgical cases were audited, and they recommended that they bill an assistant surgeon for the following scenario. And she said she's heard this more than once, probably 3 or 4 times, but she said, this is unusual to me. How can we even bill this? She said, in certain circumstances, typically trauma situations where there are multiple cases happening at the same time and there are multiple attending physicians involved where they need to be in more than one place at a time. Think the situation of overlapping cases. So Dr. Smith was available to assist if needed. Well, if that doctor was in fact needed and present, but it was more of the primary surgeon waits for the assist to show up and leaves to go to another case, they were still saying that you can bill for either a second surgeon as an assistant surgeon, and that is not the case. Unless you want to bill it as a co-surgeon, let me tell you, the primary surgeons are not happy with that because then they're going to lose a lot of money. Also, is the case even appropriate for an assistant surgeon? There's a list out there you can tell. So it's nice to have this convenience, and yes, it's a workflow with the hospital, but that does not always mean that you get to bill for it. And when I see organizations telling people that, you can bill for these standby services, even if you didn't do anything or you did a little bit, you cannot. There was another one recently where the providers were told, let me think of what this one was. They were told that if they're giving hot and cold packs to a patient as an orthopedic practice, and they just happen to press a little bit on a certain area in the shoulder or a certain area in the arm or in the back, then they could bill that as massage therapy. No, 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 no. Oh my gosh. What the heck? I'm just like, are you kidding me? People are actually telling you to fabricate, to manipulate, to manufacture charges out of something that didn't exist. There's another one, and this one is actually a workflow problem with hospitalists. So I love a hospital that has hospitalists. It's so helpful to patients, to providers that can't get to see their patient, etc. But some hospitals have a workflow policy where all hospitalists see all patients. That doesn't necessarily equal reimbursement. And I'm seeing it more and more where a patient is there for, let's say, a major global surgery, hip replacement, or, brain surgery, or gallbladder, or, even appendectomy. But these are all global surgeries. And the surgeon and their team rounds on the patient in the global post-op period. And so does the hospitalist that is not checking on anything outside the global services. They're not checking on, should they continue home medications? They had a heart problem that they needed to now come in and call the cardiologist in on, or something like that. No, they're just basically commenting on the sutures, commenting on the level of pain for the patient, saying they're comfortable, and redocumenting pretty much everything the surgeon said. That's not billable. That's post-op. And the pushback I get on that is, well, it's not the surgeon doing it, so we can bill for it. No, again, no, no, no. Remember, for those of you that are my age or, that were born before the 80s, remember the campaign out there, Just Say No? It was really about drugs. But when you talk about some of these things, you have to use common sense. I get these questions a lot, and as much as I appreciate these questions because I want to be able to respond to them, another question came in that said, we have providers that are reading x-rays from home or from the office when the x-rays are actually provided, the technical, in the hospital setting. I'm like, okay, what's the question? Well, we've been told that we should bill the interpretations as place of service, office, or home, and my head exploded. I'm like, okay, well, you need to look at R3315CP for radiology services. Okay, that's a change request, where basically Medicare says, and I'll kind of quote on this, Medicare says that the place of service coded for an x-ray done at a physician's home or in the hospital when the x-ray itself was taken in a facility would be either 22 outpatient hospital or 21 inpatient hospital, depending on where they received the face-to-face service, the x-ray, not where the interpretation of the image was performed. And the reason is this. Now, there's other rules when it comes to tele x-ray because you have to make sure about the state-to-state thing. But you have to be very careful here because remember, facility rates are 20 to 30% less than the rates that you would get in the non-facility or your office or home or anywhere that's not the hospital. So trying to manipulate the system to be able to get a higher rate from a place of service from somebody telling you. It's always, well, we were told. Who told you that? And nobody ever has a name for me. I wish I could get some names. There's a black box of names of people who are giving really bad advice to practices, and they never seem to be around or show up when you're called out on it for, from a payer, and now they're saying, give us our money back, or we're going to now audit you, or it exposes you to, you're inviting risk when you first don't check those things. And so I'm just, I wanted to caution you. I know last week I went into about being well prepared. Well, you need to also be well versed and understand a lot of the rules, a lot of the application of the rules, a lot of the information that's out there to make sure if it's accurate, if it's correct, if it's appropriate to be doing these things. When just somebody says, oh, look what you can do to make money, be careful of that. The last one I'm going to mention is the disclaimer on voice dragon EMRs or EHRs or recorded information that is documenting for the physician. And I'm still seeing this, and I don't know if you realize this, but back in 2005, the DOJ and HHS says, you know what? We don't allow for disclaimers in a record. And prosecuting attorneys love it when a doctor does a disclaimer, because they're like, that's the doctor that clearly hasn't read or reviewed the record. And now we have a leg to stand on saying, well, you signed off on it. Once you sign your record, you're responsible. It doesn't matter what disclaimer you put in there saying there could be typos, there could be this, that. I was auditing a record yesterday that said the patient hiked 9 hours a day and 4 miles a day. Well, what they meant to say was slept up to 9 hours a day. And so, even at the bottom, it says, well, it's not our fault that Dragons thought I said hiked instead of slept. Yes, it is. Because it's a patient that now, needs care from a cardiology perspective. Well, a patient that's able to hike 9 hours a day and 4 miles a day, no, they don't need anything. They're healthier than anybody I've ever met. So this is where you have to be really on top of your game. And that's why, this is an episode that I really wanted to bring out today, and basically just say, watch out for bad actors and on billing advice, because engaging in people that don't know what they're talking about will have serious consequences for both the patient, for you as healthcare providers, professionals, and more providers are engaging without checking. And we really want you to check. You don't want to get into legal, financial, or reputational repercussions. You just don't. So really check. And for those of you, we've had a lot of new membership signups because we check for you. So if you don't have the wherewithal to be able to do that, always go to my website at terryfletcher.net, go to membership, or I should say go to services. And the very first drop down is our Coding Corner membership. We're happy to help. There is a fee for it. It's a yearly fee, but better be safe than sorry, right? All right, everyone. Well, I know that today was the last Tuesday of the month, and I typically do a top 10 Tuesday. I'm going to save it for next month. We've got a few. Also, check out my website at terryfletcher.net as well, and my blog articles, because I am now putting them up on the website. I was actually a little lax in doing that, but now I am putting the top 10s up there when we do them. I'm actually going to start doing them probably quarterly instead of every month, only because it's just easier to have that single topic that I like to focus on during the podcast. So hopefully that's helpful. Also, thank you to everyone who voted for us for top female podcast and top business podcast in the healthcare space. I appreciate that. We are also number 4 on Podbean in the healthcare business space. So that's great. Number 22 on Apple Podcasts, and that's out of 32,000 podcasts. So everyone who's voting for us, who's leaving ratings and reviews, so positive. I can't tell you how much I appreciate that. This is our 401 podcast, and it's been around since 2017. So there's a lot of podcasts out there. I think we were first in the healthcare space as far as coding, billing, compliance, and reimbursement. So it was nice to kind of trailblaze for everyone that's out there. And also, I just wanted to say a side note, kind of a congratulations to my good friend Sean Weiss. We do a podcast together, hashtag Terry Tuesday from the Compliance Guy. He's not quite as consistent as I am as far as every Tuesday, but we do get on there at least twice a month. But he met with Dr. Hamed Oz, the new CMS administrator, this past week, and the good discussions, and go search out Sean Weiss on LinkedIn and you'll see his post on that. So I put a bug in his ear about trying to get the sequestration and the pay-go cut off of our Medicare reimbursement, and he said there was a good conversation. So, good luck to him. Hopefully that'll turn out to be something really important and a really, really good meeting. We appreciate all Sean's participation in this space. So everyone, I hope you have a great rest of your week. Make it a great day, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.